Welcome friends. Now we're gonna see about DKA, that is diabetic ketoacidosis. You all know diabetic ketoacidosis is a well-known deadly complication of diabetes. To understand DKA, we have to learn little about glucose metabolism. Normally, we are taking glucose in polysaccharide form. This will be digested into monosaccharides and disaccharides in the intestine and will be absorbed into the portal circulation. Once it enters the portal circulation, it will reach the liver. Through GLUT2 receptors, it will enter the liver. Some of the glucose will be stored as glycogen in the liver and the rest will be released into the systemic circulation. Once it enters the systemic circulation, it will reach the pancreas. Through GLUT2 receptors, this glucose will enter the pancreas. Our pancreas will test the glucose level in blood and will release insulin according to it. This insulin will go to the peripheral tissues and will shift the GLUT4 receptors present inside the peripheral tissues to the cell surface. Through GLUT4 receptors, the glucose will enter the peripheral tissues and will be metabolized. By this way, the insulin is maintaining the blood glucose level. With brief introduction about glucose metabolism, now we come to the pathophysiology of DKA. For DKA to occur, there should be absolute absence of insulin. This absent insulin will raise the counter-regulatory hormone level in blood. Both these things will cause increased gluconeogenesis, that is, formation of glucose from non-carbohydrate precursors, and will also elevate the free fatty acid level in blood, and these free fatty acids will be converted into ketone bodies in liver. Eventually, our blood will be flooded with glucose and ketone bodies. These ketone bodies will release H+ ions and this will cause acidosis. Kindly have a look at the table. The normal blood glucose level is 80 to 120 mg per deciliter. In DKA, we are having 250 to 600 mg per deciliter. This is due to increased gluconeogenesis due to unopposed action of counter-regulatory hormones. Normally what happens is, in DKA, we are having surplus amount of glucose in blood and it will reach the kidney eventually. Our renal threshold is 180 mg per deciliter. That means our kidney can reabsorb the glucose only up to 180 mg per deciliter. More than this level, all glucose will be excreted out. Along with this glucose, the water will also be excreted out and the electrolyte will also be lost. This is called osmotic diuresis. This will lead to total body sodium, total body potassium and all other electrolytes will be lost and will be low. But it seems like we are having raised potassium level. Why it is so? This is due to, in our body we are having H+, K+ antipode. This H+ due to acidosis will enter the cells and will push the potassium in exchange with it. So it will seem like there will be raised potassium, but actually there is potassium loss also, and the bicarbonate will be low. It will be less than 15. It is one of the differentiating factor from other ketoacidosis. In alcoholics and starvation also you will get ketoacidosis, but the serum bicarbonate level will be more than 15 in those conditions. But in DKA, the serum bicarbonate level will be less than 15. The anion gap will be increased due to raised ketone bodies. And the hyponatremia is due to dilutional hyponatremia due to increased glucose level. To differentiate DKA from other acidotic conditions, you have to take urine analysis. If you see both glucose and acetone positive, it is DKA. If you see only acetone positive but glucose negative, it might be some other conditions other than DKA. And the patient will develop nausea and vomiting due to ketoacidosis and hypotension and electrolyte imbalance that is irritating the nauseating center. The abdominal pain is due to H+ ions irritating the H+ producing gut epithelium. And the patient will also develop Kussmaul's respiration. That is due to three things: 1. Ketoacidosis, then hypotension, then electrolyte imbalance. All these things can cause Kussmaul's respiration, that is characteristic rapid and deep respiration. And patient will also develop coma, that is due to DKA, electrolyte imbalance, hypotension. And characteristic fruity odor you can smell due to acetone expiration. Once you confirm diabetic ketoacidosis, you have to take immediate action. All these things are due to hypotension, raised glucose level and potassium disturbance. You have to initially address the hypotension. You can give 0.9% saline. If the patient is in hypernatremia, you can give 0.45% saline also. After that, you have to give short-acting regular insulin. Initially, you have to give 0.1 units per kg IV stat, followed by you can start IV infusions also. Then you have to address potassium level. If the potassium level is less than 5 to 5.2, you have to give 10 milliequivalents per hour. If it is less than 3.5 milliequivalents per liter, you have to give 40 to 80 milliequivalents per hour. I hope I have given a brief idea about diabetic ketoacidosis. If you find it useful, kindly like, share and subscribe. Thank you.